It's something we've been deliberating over for the last year or two to find a better way of working closer with GPs. Being a GP myself, I know how we work best, and so do the CCG executive team. But we also realize that the CCG is comprised of practices. And if the practices are not engaged or feel ownership of what is being done, then we begin to have disengagement and GP is not interested, and without GP involvement we can't deliver the priorities that we have. So we thought long and hard, looked at what are the areas we're doing, and then went with the models that we've developed so far. Yeah, so with my previous experience redesigning or looking at the acute services review for long-term conditions across South East Midlands, we looked at grouping patients into populations of about 50,000 and sort of wrapping around the service around them. So looking at the Luton model, what we did was then group, we have 4 clusters which are grouped 7 to 9 practices, so roughly 50 to 60,000 population patient, and around the GP clusters, and then put strong support really, so align social care with that, aligning with a coordinator, so aligning with business intelligence, just to make sure it works, and so that there's feeding in of information and also outputs and outcomes from the clusters. Basically give GPs autonomy and that power to actually decide the direction we want the patients to go, which is better quality and better care, and also to address practice variation as well and use as a peer support to improve. We did it fairly quickly. I think once we decided, then it was swift. I think we spent more time deliberating on thinking whether to do it or not. So we sort of decided in January we're going to start working on it. By May we had quite a good structure, and I think by the end of May we had our first meeting. But things really kicked into gear in July. Sometimes we do feel quite fatigued about the change and another way of doing things again. So it was just overcoming that, will this work? Is this just another sort of bureaucracy, something that's just going to inundate us again? So that's been the biggest challenge, and I think overcoming that for us has been with quite a lot of engagement and discussion and communication. We are still working through the challenge, and as I shared before in Salford, that it's a work in progress. It's almost like an accountability thing for us now that we've started this. We have to make it work. So the main thing for us is making sure that communication is not lacking. Actions into the clusters are followed up quickly, and so GP opinions are fed back. So if you have, we want to do this in this cluster, for instance, and then we say we're going to support you with the management of it. They want swift action to say, well, we've had a look at this. This is support around that project. Off you go and do it, rather than having things waiting and nobody's views being taken into consideration. We've been lucky because before we set up the cluster model, we had what we call the primary care investment scheme or improvement scheme, which some areas have also adapted in the past as well. We tried that model, but we didn't well. So we had some resource so aligned to that. So we just allocated that resource to developing the cluster model. So we've had to employ coordinators. We have a primary care development manager. We've had to obviously resource the GPs who are championing and pushing it. It has to be resources. It can't be done without adequate remuneration and resourcing. Well, there's been quite a mind change, so things have really quite changed. At the beginning, we were insisting with our social care colleagues that we wanted social care aligned to the practices. So now we then had that resource. So we have a social care manager to practices. So where we're looking at projects, for instance, like diabetes, we're looking at the total person, not just looking at the disease-specific conditions, but also, are they getting the care they need? Do we have any unplanned admissions, and why? And are there quick discharges? So we're looking at pieces of work. So the frail elderly work, if people are going to hospital, is there social services to sort of accept them back home? So as soon as we have our patient now, and which are aligned by cluster, being admitted, the DME consultant, who's also aligned, by the way, with our clusters, sets the work in motion immediately. GPs contacted, social services contacted, and the discharge is planned as soon as the patient arrives. have a very robust community nursing team that actually supports the patient in the community, and that's a piece of work that we're doing. So, for instance, our patients with open access to the hospital, now the community nursing team has that caseload. They know who they are, and they can actually liaise directly with the community nurses, which is very handy. Age Concern are quite active in Luton. We've done quite a lot of work with meet and greet, which is supported by Age Concern, which is when they meet the patients at the hospital, and they're very involved with our work with the frail elderly piece of work we're doing. And all this work we do in Luton is now everything goes through clusters. It's never a piece of work in isolation. It's all looked at via the clusters and delivered that way. I mean, thinking about that, we had the housing director for our council. She sits on our commissioning committee where the decision for the cluster to develop the cluster was made, and she's so heavily involved in that piece of work. I mean, we often don't think of housing early enough in the process, and I think the way we're going to get into that is via the social care, and then they plug into housing, because she leads not just on housing but also on social care. A practical example, if I'll give you one quickly, is a children's phlebotomy service, and it costs us quite a lot of money for children to go into hospital to go and get their bloods taken. I mean, I won't quote you figures here, but it's in the hundreds per patient. Actually, we can deliver that service if we federate and have our model and have one GP practice or two delivery for the whole of the population. So that's a piece of work that's been looked at, and there's a myriad of others that have been worked through. We are looking at metrics. That's one way of measuring. So we're looking at things like how our referrals going, because we had issues in Luton before in terms of unplanned admissions, then sort of elective admissions into planned admissions, our first outpatient referrals. So we're looking at those key metrics, but actually looking at that in isolation is not sufficient. We're also looking at outcomes in terms of engagement, with GPs, so the energy and the pace behind the project. Are we having buy-in and ownership as well? So far, I'll say engagement, we have the cluster chairs very well engaged. All the meetings are attended, so people are sort of around the table. We're getting people around the table, which as GPs, if you're not interested, you just won't turn up because you're just not interested. But we have that, and the metrics, the clusters are reporting their metrics weekly, but now some of them have gone to monthly. So looking at all those key indicators I mentioned before, not just those, but there are quite a few others. And one crucial thing for us is to give the clusters ownership and autonomy to run with this. We're even going down the line of cluster budgets that clusters can have sort of ownership of and hold, but that's in the making. So in terms of measurements of success, it's metrics, but it's also in terms of quality and outcomes. We have a lot of work to do. We cannot rest on our oars. We have so much to do in terms of delivering good care, in terms of being in financial balance. So I'll say it's early days for us. We want to just keep sharing what we're learning as we go along. We're never afraid to tweak things and change things around if we have to. But right now, it's the hard graft we're doing and the hard work we're doing. So federating, as you said, getting practices to know that they have the power to do a whole lot more. Come together, deliver services as providers, co-commissioning. So there's quite a lot to be done. And looking at the whole thing as a system, and not having, with a 5-year plan, and not looking at GPs in isolation, but the cluster model incorporates everyone. And as I described to you earlier, even acute care, our secondary care colleagues, it's a system ownership, and that's what we're trying to foster. I'm hoping I don't have to convince any GPs after everything I've said, to be honest. But what I share with my colleagues and what they share back with me. In fact, I think it's more what they share with me and with the rest of the exec is in terms of just knowing what your colleagues are doing. We've practiced for so long, just in our practices, looking at our figures. Actually, difficult to share the learning or to do anything. So that sort of peer-to-peer review that is wanted and accepted is challenging, but at the same time encouraging in a constructive way. So I'll say I find that particularly rewarding. and hopefully other GPs find that so as well. Being able to identify areas where you want to work on, also in line with the organizational goals, and taking us to where we're trying to get. It's rewarding, so you can see a direct impact of what you're doing in the figures, and that's quite a lot of control. Going into so many others, working across the system, we know how difficult it is in your day-to-day job to get social services, to see a patient on Christmas Eve, and trying to avert an admission that is unnecessary. But now we have a direct number and who to ring if that so happens. Again, working with the acute sector and how easy I have a mobile number for the DME consultant aligned with the cluster. It's just that integrated way of working, which is refreshing and is welcome. It's not easy because people still have to change mindsets, but it is refreshing and delivers better outcome for the patients. They can stay at home longer, where they should be in the right circumstances, and they go in, targeted care and back in the comfort of their own home with the right support. It's a no-brainer.